if you wanted to. Thank you. So good morning, everyone, and thank you for joining us. Today, our speaker is Dr. Kevin Staples. Doctors are often asked to make decisions about patients' medical fitness to drive. Medical driving restrictions can improve road safety, but are known to have substantial social, occupational, and quality of life consequences for the individuals who must cease driving. To date, very few empirical data have informed clinical fitness to drive guidelines. In this webinar, Dr. Staples will discuss recent research from his lab that uses a unique set of linked administrative, health, and driving data to generate evidence to inform clinical fitness to drive decisions. The talk will highlight study designs with broad application to injury prevention research, including cohort, case crossover, and responsibility studies. He will focus on fitness to drive decisions for individuals with high priority conditions, including schizophrenia, syncope, and recent cardiac defibrillatory implantation. Sorry, excuse me. It's medical jargon.
Exactly.
Dr. Staples is a physician at Vancouver General Hospital and a health professional investigator supported by Michael Smith Health Research BC. His research has been discussed in New York Times, The Washington Post, Times Newsweek. For those joining us in person, if you have any questions, please feel free to raise up your hand during the presentation. For those joining us online, if you have any questions during the presentation, please enter them into the chat box at the bottom of your screen. After the presentation, you may unmute your audio line to ask questions, or we will monitor the chat box for questions or any comments you may have. We are now ready for the presentation. Dr. Staples, over to you when you're ready.
Okay, thanks. Thanks, Farah. Appreciate that. So, if questions come up, someone should feel free to interrupt by unmuting, because with my screen set up, I may not see your hand going up. So please feel free, particularly if I'm diving into medical jargon that people don't understand. Feel free to interrupt. You don't have to wait till the end. So thanks very much for hosting me today. As you heard, my talk is entitled Safe Behind the Wheel, using clinical epidemiology to inform decisions about fitness to drive. And let me just, okay. So the objectives today are to describe some of the recent studies from my lab that examine driver fitness, and to think about different study designs that can be used across the field of injury research and may be applicable to your own work. By way of conflict of interest disclosure, I'm a pedestrian, a cyclist, a driver, a clinician, and a researcher, and all those things color my research, and that's probably a good thing. I have some competitive research funding from CIHR and the Heart and Stroke Foundation of Canada, and I don't have any commercial interests. In terms of the obligatory UBC conflict of interest mitigation, I'm going to try to be objective when interpreting the results of my studies. I had editorial independence in the composition of the talk, and funding organizations weren't involved in the design or conduct of studies, collection, management, analysis, interpretation of data, or the preparation, review, and approval of this presentation. And then one more disclaimer on behalf of data stewards that all the inferences, opinions, and conclusions in this presentation are mine and those of my co-authors, and don't reflect the opinions or policies of the data stewards. Okay, with those pieces of housekeeping out of the way, we're going to talk about driver fitness today, which is a bit of a niche topic and one that's a little bit unusual for a general internist like myself to get into. But, as Farah was saying, I work about a third of my time as a clinician, primarily in the hospital, and this is an issue that sometimes comes up for me. So in about 10 years ago now, I met a young woman some physicians from surgery called me and asked me to see a 38-year-old woman who was admitted to a hospital for a very serious traffic injury. She broke multiple bones and had to go through a number of surgeries. And they called me because they couldn't figure out why she'd crashed. On her description, she was driving early in the morning. The weather was good. The roads were dry. She was the only vehicle on the roadway. There were roads that she knew well and understood. And essentially, she had no recollection of the event. She remembered driving along and being well. And then the next thing she remembered was waking up after crashing. She was certain she hadn't fallen asleep. And when we examined her and did a number of tests, everything really seemed normal. And her question for me was, should I stop driving and for how long? And this was an important question for her because she was a large animal vet. So if she had to stop driving, even temporarily, she couldn't work. So it was a big deal. So I went to clinical guidelines, and found that there were some guidelines, but the studies underlying those guidelines weren't very good. And it was very unsatisfying to me. I really couldn't give her very good advice. And that prompted this whole line of research. So the problem with a lot of the current driving restrictions is they're based on pretty limited evidence. As I say here, there aren't very many studies. Typically, they're very small studies. Often they recruit their patients from specialized clinics, and so they're not necessarily representative of the general population. Many studies rely on patients telling the researchers when they crashed and how much they drive, which might underrepresent the true number of crashes. And a lot of the guidelines rely on back of the napkin calculations. So very low evidence basis for what can be a very high consequence decision for patients. So I think it's fairly obvious, but needs to be said that not being able to drive is a big problem. For many people, it threatens their employment, either because driving is their employment or because they need to get to work. It limits our ability to socialize, reduces quality of life. It's associated with depression and anxiety. And I want to highlight particularly patients who have a cardiac defibrillator implanted. So this is a device that shocks the heart and can save lives, but requires a surgery and frequent follow-up and a number of other uncomfortable procedures. For those patients, they identify the driving ban as the biggest problem, not the surgery and not the follow-up. So this is a big, big problem for patients. Medical warnings or medical driving restrictions probably work. And I say probably because there's not very much data. But the figure I show here is from a study from my friend, mentor, and colleague, Dr. Donald Redemeyer at the University of Toronto. And they examined 100,000 patients who physicians had reported as potentially being unfit to drive. And you can see that time zero here on the x-axis is when the report occurred. And they looked back in time to see the rate of crashes in the 4 prior years. And they looked forward in time to look at the rate of crashes in the subsequent year after reporting. And they found that reporting itself reduced the risk of crash by about 50%, which is pretty good. Now, this might seem a bit self-evident that when individuals are reported, they're going to crash less. And in 10 to 30% of cases, people had their license withdrawn. But in many cases, licenses weren't withdrawn. And so people maybe altered their driving habits or had their medical problem fixed. And in any case, it was an effective intervention. So they're effective, but they're not perfect. And that's because people aren't perfect. So this figure is from a study where at time zero on the x-axis, everybody was told that they cannot drive for 6 months. And then researchers did phone interviews with these patients and asked them about their driving. And by the time the driving ban ended, about 60% of patients were already driving. So adherence to driving restrictions aren't very good. And that's going to be important for interpreting the research that we'll talk about today. So first, I want to talk about syncope. So syncope is a common faint. So the technical medical definition is an abrupt and transient loss of consciousness associated with the absence of postural tone, followed by complete and usually rapid spontaneous recovery. So if you've seen somebody faint in a movie or in real life, that's really what we're talking about today. People fall down, but then they wake up almost immediately thereafter. Syncope is very common. I imagine that a number of people on this call will have experienced it. Some estimates suggest that up to 1 in 3 people will experience syncope over the course of their life. It causes 1% of all emergency department visits, which doesn't sound like much, but in the United States, that adds up to 1.3 million emergency department visits per year. So it's a very, very common problem. Of interest, it's been described for over 3,000 years. So this is Hippocrates, famous for the Hippocratic Oath, but a famous Greek physician. And one of his aphorisms was, "Those who suffer from frequent and severe fainting often die suddenly." Pretty ominous. Now, I'll point out that that's not true of most people who have syncope. So this is a Kaplan-Meier curve from the Framingham Heart Study. So Framingham is a town in Massachusetts where they've done a long-standing cohort study for many decades. And in this study, they looked in particular at individuals who had syncope and followed their probability of survival over time. So you can see on the x-axis here that the follow-up time is 25 years, quite an impressive duration. And in black, you can see that this is people without syncope. And people were older when they were recruited. So there was a number of people who died over 25 years. But this is the baseline of people with no syncope in black. And then people with vasovagal syncope, that's a common faint, are shown in yellow. And you can see their survival is identical to people without syncope. But in comparison, in red here, you can see people who had cardiac syncope, so passed out because their heart stopped or was beating too fast, or they had a very tight heart valve, what we call cardiac syncope. And you can see that they were much more likely to die. So I point this out because for syncope, the type of syncope really, really matters. Now, when somebody shows up in the emergency department with syncope, we have to think about what to tell them about driving. Driving cessation or driving restrictions after syncope are quite complicated, and there's too much here on this slide for you guys to really think about all the different nuances. But what I want you to focus on here is what I've written in red. So for someone's first episode of syncope, if it's a typical faint, there's no restriction. People can drive home from the emergency department if they wish. Maybe the second most common thing is the second line I've highlighted in red here. For people who have a single episode of syncope, for which there's not a very good explanation, they might be told not to drive for a week. And so I want you to keep that 0 to 1 week range in mind as we chat. So I first wanted to talk about the cohort study that we did to look at syncope and the risk of crash. So what we did is we took, we identified a group of about 10,000 people who visited an emergency department here in the Lower Mainland for syncope. And then we matched those people on a 4-to-1 basis by age and sex to people who visited the same emergency department in the same month, but for something other than syncope. And we identified those people as our control individuals. We verified whether they had syncope or not because we had hired chart reviewers to review their emergency department charts. We obtained lab data and electrocardiogram or ECG data from Vancouver Coastal Health and linked that to their abstracted chart data. We linked that to administrative data from Population Data BC, including hospital records, emergency department records, and clinic visits with their physicians. And then linked that to crash data and contravention data, which means traffic ticket data, that we all obtained from ICBC. So multiple sources of population-based data. And one of the reasons BC is a great place to do this kind of work is because we have population-based health data and population-based driving data, and there are not a lot of other places in the world that have that. So we took this cohort of about 10,000 people with syncope and their matched controls of about 40,000 people with a visit for an emergency department visit for something other than syncope. And you can see here on the top line, this represents time, proceeding from left to right. And we centered things on their syncope emergency department visit, highlighted here in blue. And we looked back in time to look for hospitalizations and clinic visits and prior crashes and prior traffic tickets or contraventions to get some idea of their baseline characteristics. And then we looked forward in time for 1 year to see if they crashed. And I'm just going to pause there. Maybe somebody can tell me, can you see my mouse on the screen?
Yes, we can.
All right. Okay. Excellent. Thanks so much. So yeah, so we did that for patients with syncope, and then we did the same for patients with a visit for something other than syncope. So this is a Kaplan-Meier curve. On the x-axis is time since their emergency department visit in days, so going out for 1 year. And on the y-axis is cumulative crash incidence, so starting at 0 and going up over time. And after we applied some exclusion criteria, we had just over 9,000 individuals with an emergency department visit for syncope, and then about 4 times that number of controls. And we followed them over time. And you can see here that in red is the cumulative crash incidence of people with syncope, with an emergency department visit for syncope, and in blue is the cumulative crash incidence of controls. And so at the end of the day, after applying censoring criteria and adjusting for a whole host of factors, including their medical history and their driving history, we found that syncope was not associated with subsequent crash, with an adjusted hazard ratio of about 0.9, which was very reassuring. So we did a number of other comparisons here, and this is a point that I really want to highlight because it's relevant to our study designs. So when we compared syncope to controls, as I just showed in the last slide, our hazard ratio was 0.9, and it wasn't significant. There was no difference in crash risk between syncope patients and controls. But when we compared the incident rate of crash among individuals who'd experienced syncope to the incidence rate of crash among the general population of licensed drivers in BC, we actually found that individuals who had an emergency department visit for syncope were more likely to crash, about 50% more likely, with an incidence rate ratio of 1.5. So this raised the concern that, possibly the result you get in these relative risk measures is going to depend on what controls you select. And this is particularly important because around the time we started this project, a paper was published from Denmark that compared to the general population of drivers and concluded that syncope doubled the risk of crash, so quite different than our result. So we went on to perform a case crossover study. So this is a bit of an unusual study design, and I want to take a minute to describe it, and I want people to interrupt if I need to clarify. But essentially, the case crossover study is almost like a case control study. But instead of comparing somebody who experiences the outcome to a control who did not experience the outcome, you compare an individual to themselves. So it's a self-matched design. So what do I mean by that? Well, in this case, we took individuals who had experienced a crash, as shown with the red X here. And we looked back in the 1 month before their crash and said, did they have an emergency department visit for syncope? And then we took a period 6 months prior to their crash to establish a control date. And they didn't have a crash on that control date. And we said, in the month before that control date, did they have an emergency department visit for syncope? And you can compare the likelihood of this exposure, syncope, before crash and before the control period, as you would for a case control study to obtain a risk estimate. So this is the simplified version. In practice, we actually use more than one control date, sort of 1 to 3 in most of the work that we've done. So the advantage of doing this is that instead of having to choose a group that you're comparing to, the general population or other people in the emergency department, you're comparing individuals who crashed to themselves, but at an earlier period. And so it's excellent for accounting for factors that are relatively fixed over time, things like genetics, race, prior driver training, driving habits, chronic comorbidities, all those things that may be measured and maybe you can put in your regression model, but may not be measured and you may not have any access to. But whether they're measured or not, this self-matched design is going to account for those relatively fixed characteristics. Okay, so we're not the first to do this. This has been done in a number of areas, including road safety. So as you see here, there are some pretty seminal studies that looked at crash risk and found that it was increased by cell phone use with a odds ratio of about 4, that intoxication with alcohol increases crash risk by 2 to 5-fold, that on-call shifts by medical trainees, so that's medical residents working in the hospital, doubles the risk of crash, and also work to show that speeding tickets and other traffic contraventions decrease or are associated with a lower risk of crash. So it's a well-established method. So in our case, we took about 3,000 crashes that resulted in a police attendance or an insurance claim, and that had occurred in our cohort of individuals who also had syncope. So it was a nested case crossover study. And we looked in the 28 days prior to their crash to look to see if they had a visit for syncope in that interval. And we also looked in the 28-day period prior to 3 control dates to look to see if they had an emergency department visit for syncope in those control intervals. And after doing so and adjusting for time varying coefficients, which I'll speak to in a minute, we found that the adjusted odds ratio was 1.3 and it didn't reach the level of significance. And this suggests that our cohort study that compared to other individuals in the emergency department was on the right track, that syncope, an emergency department visit for syncope doesn't seem to be associated with an increased risk of subsequent crash. Now, in terms of things to adjust for, I mentioned that the case crossover study can account for fixed characteristics like genetics or personality or prior driver training, but it doesn't necessarily or doesn't necessarily account for variables that might change over time. So a good example is, let's say, alcohol use over time might change. There are periods of time where people might be stuck in their addiction and periods of time where they might be sober. So this wouldn't necessarily account for that. And so in our study, we tried to account for some of those factors that might vary over time. I'll gloss over that in the interest of time today. So that was very reassuring in terms of trying to figure out if bias from the selection of our control individuals biased our null finding from our primary study. But another question came up about whether people might have stopped driving. So you can imagine if you have an episode where you pass out, it doesn't have an explanation, you might be shaken by that, you might decide to stop driving permanently. And unfortunately, we didn't have any good information about the number of miles or the number of hours people were driving per month. So that's not something we could control for. We did look in our cohort study at a couple things. We looked at their rate of contraventions, again, traffic tickets, both among syncope and control patients. And we found that there wasn't any major difference between the two, maybe slightly lower among syncope patients. And we also looked for hospitalizations for injuries that resulted from motor vehicle collision as a non-driver. So that means as a pedestrian or as a passenger, thinking that if people stop driving, they'd be more likely to be pedestrians, cyclists, or passengers, and maybe that would be reflected in the injury rate. But it was so rare that it wasn't really helpful. So we were stuck with this problem of knowing whether or not people were driving and what their driving exposure was. So we went on to perform a responsibility study, and this was all pre-planned as part of our study in advance, and relies to a great degree on the work of Jeff Brubaker and Herb Chan at C2E2. Jeff's also an emergency physician at VGH, and they have worked quite a bit on what's called a culpability study or responsibility study. So I'm going to try and explain what that means. So in a responsibility study, you take a cohort of individuals who've experienced a police-reported crash. And every time that police attend a crash, they have to fill out very detailed information about the crash and about all the drivers involved. And that information is stored in a big data set. And so Jeff and Herb and colleagues went to that data set and with experts developed a score based on these structured data elements that could predict the likelihood that individuals were responsible for their crash. So for example, somebody who crashes when they're the only vehicle on the road and the weather is great and the light is good and the road is straight, that person's probably responsible for their crash. Maybe they fell asleep at the wheel, maybe they were intoxicated, etc. But if somebody is driving on a snowy, dark night and they're stopped at a stop sign, obeying all traffic rules, and somebody else rear ends them, then that first driver who was stopped at the stop sign is likely not responsible for their crash. So this score can be used to sort people into responsible or not responsible. Then you can take individuals who are deemed responsible for their crash and look back in time to see, did they have the exposure that we're interested in this case, an emergency department visit for syncope. And you can do the same for people who are deemed not responsible for their crash. You look back to see if they had this exposure. And you can compare the likelihood of exposure prior to responsible crashes and prior to not responsible crashes and come up with an association with an odds ratio. Again, this responsibility study is kind of like a case control study. So this is a busy slide. I want you to just focus on what's written here on the right-hand side. Predominantly the things that determine whether drivers are deemed responsible for their crash. First of all, if they're driving in an unsafe manner as identified by police, including if they broke any laws. And secondly, if somebody else contributed to the crash. So as I said in my example, if you were rear-ended by another vehicle, then you're more likely to be deemed not responsible for your crash. So in our case, we identified 475 police-attended crashes occurring in BC during our study interval among individuals who had syncope or had an emergency department visit for syncope in the interval as well. We divided them into those who were responsible for their crash and those who were deemed not responsible for their crash, excluding people with indeterminate responsibility, as is standard in this study, and then looked back in time to see what proportion of responsible and not responsible drivers had an emergency department visit for syncope in the months prior to their crash. So there are a few different ways of saying this, but if we looked at individuals who had syncope and a subsequent crash, 69% of them were deemed responsible for their crash. If we looked for individuals who did not have syncope and crashed, or did not have recent syncope and crashed, then only 61% of them were deemed responsible for their crash. Again, sort of generating this adjusted odds ratio of 1.3, suggesting that there's not an association between syncope and subsequent crash. So just to summarize here, we did 3 types of studies. We did a cohort study, which found that syncope was not associated with subsequent crash. We did a case crossover study, which was able to account for fixed individual characteristics, which again found that an emergency department visit for syncope was not associated with subsequent crash. And we did a responsibility study, which found that crash responsibility was not associated with prior emergency department visit for syncope. And this differed a little bit from this Danish study that I talked about that found the doubling of risk among patients with syncope. So overall, some reassuring information that from a clinical perspective, we have a lot more evidence that what we're doing is okay, that we're on track, we're not missing some large risk for crash. So I want to move on to our next set of studies here that look at ICDs. So an ICD is an implantable cardioverter defibrillator or implantable cardiac defibrillator. It's a device that's about the size of a pacemaker that's inserted under the skin, kind of by the collarbone here. And wires are floated through the veins to the heart and implanted inside the heart. And this device, if it detects cardiac arrest, specifically ventricular tachycardia or ventricular fibrillation, it can deliver a shock to the heart and reset it. So just like on TV, when you see the emergency department doctor rub the paddles together and shock the patient to reset their heart, that's what this device is doing, but it's doing it inside the body. So these devices are life-saving. There have been lots of randomized controlled trials to show that they prevent death in the right set of individuals. And so they're very helpful in the right context, but there are some challenges with them. So when you are shocked, patients say it's like being kicked by a horse in the chest. It also causes muscles to contract, and so people will jump or jerk. Similarly, individuals that have these devices, they have them because they're at risk of cardiac arrest, and cardiac arrest itself can cause people to pass out. So obviously, either if you pass out or if you have this kick in the chest by a horse, either of those things might make driving unsafe. And if it were to happen while you're driving, you might crash your car and hurt yourself or hurt somebody else. So for decades now, physicians have been concerned about the risk of crash with ICDs. I wanted to highlight a paper that was published a few years ago now, which was a detailed examination of one specific crash where a truck driver saw an oncoming vehicle, saw the patient or the driver slump over and subsequently drift into the oncoming lane, and caused a crash, which resulted in the driver's death. And an autopsy was done, including explanting or taking out their ICD and examining it to see what happened. And the coroner and the authors of this article concluded, as I say here, the driver of the SUV suffered from ventricular fibrillation, which resulted in fainting, loss of control of the car, and in consequence, a road traffic accident and the driver's death. So all of us in injury prevention bristle a little bit with the term accident, but the point here is that these abnormal heart rhythms or cardiac arrest can result in crash and fatality. So in the course, over the study interval that we'll be talking about the restrictions in Canada, there were some restrictions after an ICD was implanted, and that's because after the implantation, it's believed that the risk of an abnormal heart rhythm or false alarm shocks to the heart is higher than once things have settled a little bit. So for people who have not suffered a cardiac arrest and have an ICD put in, they were asked to stop driving for 1 month. For people who'd had a cardiac arrest or one of these abnormal heart rhythms, they were asked to stop driving for up to 6 months. So those were the driving cessation restrictions. Now we're going to talk again about these 3 study designs: the cohort study, where we take exposed folks, which I have in black here, and unexposed folks, which are represented in white, and we look forward in time for the outcome of interest. We're going to talk about case crossover study, where we take everybody who's had the outcome of interest, in this case a crash, and look back in time to see, have they had this risk factor, and then do the same in an interval, a control interval, where they did not have the outcome of interest. And we'll talk about a responsibility study, which divides crash-involved drivers into being responsible for their crash or being not responsible for their crash, and looks back in time to see if they were exposed to the risk factor. So in our cohort study, we identified individuals with a first ICD implantation over about 20 years and matched them each to 3 controls. And we looked forward in time in the first 6 months after their implantation or after their matched implantation date to see if they were involved in a crash resulting in attendance by police or in an insurance claim. And we right censored for things like death and license expiry and a number of other things. So in our cohort study, we identified about 10,000 people with an ICD implant and about 30,000 controls. They were older because people are more likely to have an ICD implanted if they have a cardiac arrest or other cardiovascular disease. I'll note here that about 20% of our cohort didn't have an active license at time 0, but those individuals were censored and so didn't contribute to our analysis. So again, here's a Kaplan-Meier curve, which is not adjusted because it's a Kaplan-Meier curve. And you can see here that time proceeds from 0 days on the left to 180 days or 6 months on the right. And on the y-axis is crash-free survival probability. And in red are ICD patients, and in black are control patients. And you can see that ICD patients actually were less likely to suffer a crash than controls. And using our Cox proportional hazards regression, we found an adjusted hazard ratio of 0.7, suggesting that ICD implantation was protective against crash, which is unintuitive. Now we took this is just to illustrate that we looked at the monthly crash rate before and after implantation of their ICD. So in this case, this was secondary prevention ICDs, just for example, and the red line is the implantation date. And we looked in each month before, and we saw that immediately after implantation, the relative risk of crash in people with implantation versus controls was much lower. And that's not because the ICD prevents crashes. It's because people are less likely to be driving because we told them not to drive and because they just had a surgery. And so this illustrates that although the cohort study is very helpful and can yield some useful information, it's not good enough to address issues related to exposure. So I also want to talk about, again, the issues related to selection of controls. So as I point out here, individuals have an ICD put in because they have cardiovascular disease. So when we age and sex match controls, we find that cardiovascular comorbidities are way more common among people who have an ICD put in. So as I say here, heart failure is 23 times more common among ICD patients than among controls. Myocardial infarction or heart attack is 18 times more common. Syncope or a history of having passed out is 14 times more common, et cetera. So we adjusted for these comorbidities, but there might be more things that we don't know about or haven't measured or can't adjust for using regression. So we performed a case crossover study that uses self-matching to account for relatively fixed characteristics. So in this case, we took and did a nested case crossover study. We took about 3,000 individuals with an ICD implantation and a subsequent police-reported crash. We looked in the 6-month period before the crash and then in matched 6-month period before a non-crash event date or a control date and adjusted for time-varying covariates. What I want to show you here is first, just take a look at what I've written in red here. This is the main analysis. So this is looking in the 6 months before the crash and the 6 months before a control date, and found that ICD implantation, the adjusted odds ratio, the 95% confidence interval crossed 1, suggesting that ICD implantation is not associated with a subsequent crash. The rest of this graph shows a sensitivity analysis with different look-back periods. And so over here on the left, you can see when we used a 7-day look-back period before crash and before the control date, that ICD implantation appears strongly protective against crash. And again, this reflects the fact that people are not driving. So that's reassuring, but doesn't speak to the actual effect of the ICD itself. So the case crossover study, very reassuring that difference in cardiovascular comorbidities wasn't driving our results, but didn't speak to the lack of exposure. So we went on to do a responsibility study. And so we took about 1 million drivers who were involved in a police-attended crash in BC over a 23-year study interval. And we looked in the 6 months prior to their crash and in the 6 divided crashes or divided crash-involved drivers into being responsible and unresponsible for their crash, and then looked at the relative or compared the likelihood of exposure to ICD implantation prior to crash responsible driver crashes and to crash non-responsible driver crashes. And essentially we found, unfortunately, that we ended up with very wide confidence intervals and an adjusted odds ratio of 2.2, but not significant. And we think that this probably just reflects what we found in our other studies, that very likely ICD implantation is not strongly associated with subsequent crash, but there's some uncertainty there related to exposure because of our wide confidence intervals in the responsibility study. So we think that the post-implantation driving restrictions could be made less burdensome. So a shorter restriction, less than 6 months, and it probably won't increase risk very much. And subsequent to that, in fact, they've liberalized the restrictions, and so we're going to get a bit of a natural experiment to figure out what happens. Now, I wanted to also chat about schizophrenia and its relationship to crash, but I'm mindful of time. And so maybe it makes sense to set that aside for now and simply go to questions to see if anybody has anything they want to chat about. So I'll just do my couple summaries here for folks, and if there are questions about schizophrenia, I'm happy to answer them later. So in terms of a summary, I want people to emerge from this talk thinking a little bit about these three study designs and their relative advantages. So the cohort study design is easy to interpret and easy to explain. It gives absolute risks as well as relative risks, and it can account for competing risks such as death and censoring from things like license expiry. But there can be bias that results from the selection of control intervals, and if you don't have good data, you might not be able to account for exposure. The case crossover study in the second row here, you can see that the main advantage is that it counts for relatively fixed individual characteristics, whether you have data on them or not. That self-matching design is a very powerful way of accounting for those fixed individual characteristics. And because it's a case crossover or a case control type design, it may be more efficient for rare outcomes. The cons are that it can only really effectively examines transient risks, although there are some ways to get around that. And it's a bit complicated to explain, which has made it a challenge sometimes with reviewers. And then finally, the responsibility analysis or culpability analysis. The main advantage is it can account for road exposure, which is really important because we typically lack data on how much people are driving. And the main disadvantage is that it requires a number of assumptions, and it's quite complicated to explain. And that can be a challenge as well, convincing readers, reviewers, and policymakers that they can strongly trust the results. So overall, medical conditions can have sort of a modest but very important influence on driver fitness. We talked a little bit about the study designs, and in particular the advantages of case crossover and responsibility designs. And I'll draw things to a close there. I wanted to thank all my many co-authors, in particular Dr. Brubaker, who's been a great mentor and a colleague for me, and Meisha Khan, who works as a research assistant in my lab and has been part of many of these studies. I also want to thank CIHR, the Heart and Stroke Foundation of Canada, and the UBC Division of General Internal Medicine for their support for these projects. And I wanted to thank the Vancouver Coastal Health Research Institute and Michael Smith Health Research BC for their support for my research time. And I'd be happy to answer any questions.
Thank you so much. That was so very interesting, and especially applying the medical field with the injury research area. That's totally interesting for me. So thank you so much for that presentation. If I can just open it up for questions. I know there's one question in the chat, and if others have questions, feel free to put them in the chat box, or you can unmute and speak out your question. But I'll just read the question that's on the chat right now, where Janet asked, where can we hear about your schizophrenia research? It would be of great interest to her team. And as a case manager that determines driver medical fitness. So she's coming in that lens.
Yeah. I mean, that's really exciting, and I'd love to chat with you more about that. We haven't published our findings yet, so it was going to be pretty hot off the press. I can't point you toward a publication yet, but maybe Janet, you and I can connect offline, and I'd be happy to chat with your team at some point about what we found so far.
Any other questions? Yeah, Burton, go ahead. If you can unmute and ask your question.
Thanks very much, Dr. Staples. I'm the driver fitness medical advisor in the province of Manitoba, and I guess something we share is a public auto insurance corporation and obviously a public health insurance plan. And this is definitely something that we are quite interested in doing, is this type of research. And our observation, as I think most people's, is that there's so much of standards that are frankly based on consensus and not very good data. Now we're pretty interested in pursuing this. We are facing administrative hurdles in terms of having access to Manitoba health data. I'm just wondering if these were hurdles that you faced and how you how you dealt with those.
Yeah. Thanks very much for your question. Yeah, I'm excited to have a fellow Prairie person joining. I'm from Edmonton. So thanks very much for your question. So yeah, this was a big hurdle. I will say that we won money to do this in January 2016. So the syncope work took 8 years to get it done, and that's primarily overcoming the administrative barriers. It wasn't the technical challenge of doing the actual research. So it's very difficult to convince data stewards, particularly across disciplines, that it's going to be okay to share data. And so that was the big struggle. It's been a longstanding challenge in BC, as in many jurisdictions. I wish I could say that we've cracked the case and it's going to be easy moving forward, but I don't think we have. And it's a great discouragement to other research that tries to answer these questions. And I think that the answer is going to have to come from policymakers, not just researchers, because the amount of effort and time it took to try to get this linkage and get this research done was way too much. So I can't take on any other projects in this area because it's just not feasible to move it forward. So we'll finish off the projects we're working on and then turn to other topics. So that's a bit discouraging, and I hate to end on that kind of note, but that's the reality of it.
Thank you. We'll try to forge ahead.
Yeah, and I'll also say that feel free to reach out. I'd be happy to chat with you in future about sort of what we did and the ways that we solved the problems that we came up against.
Thank you very much.
Neil, if you want to go ahead.
Okay, great. Yeah, can you hear me okay?
Yeah, hi, Neil.
Yeah, hi, Dr. Staples. Thank you very much for your presentation. It's very thorough, and methodology, I think, gives a lot of confidence around the results that you've been able to obtain from these various medical conditions that you've studied. And so my question is just, the only thing I'm wondering about is, I think I saw in the concluding slide there, medical conditions don't have much of an impact, right, on driving based on, but I guess my question is just to be, but I guess there's a lot of medical conditions, right? I'm not sure, maybe you haven't had an opportunity today to share your findings around all of them. So that's part of my question too, but I'm just thinking like, there's like vision loss, there's dementias, there's all these other things. And I think like I have seen evidence that some of those things, so I just wondered if, is it more the conditions that you've studied here and shared with us, they don't seem to increase crash risk much versus all of the various medical conditions that people can have? I'm sorry, is that a fair kind of question?
That's a very fair question, and thanks very much, Neil, for raising that. So yeah, I mean, the topics that I talked about today don't have a strong influence on crash risk, but that certainly doesn't mean that nothing does. Some of the ones that come to mind, so kind of somewhat unsurprisingly, but importantly, things like alcoholism or alcohol use disorder, is strongly associated with subsequent crash risks. in a way that we probably haven't thought very deeply about from the medical side. Seizure disorders are strongly associated with crash risk. Obstructive sleep apnea makes people very sleepy, also strongly associated with crash risk. And so those are some of the ones that have some of the best evidence for risks. I suppose what I meant by my comments at the end are particularly important to keep in mind sort of scale and overall risk. So, one of the findings that I didn't touch on is we did a responsibility analysis looking at schizophrenia. So schizophrenia can impair judgment and perception, and people with schizophrenia are often subject to driver license restrictions, and that's been the subject of a BC Supreme Court case in the past as well. So we found in our responsibility study that schizophrenia was associated with subsequent crash with an odds ratio of about 1.7. And so it would be tempting to conclude, well, the risk is higher, so we better restrict those people. But I think it's really important to keep in mind the consequences for individuals who are already very marginalized, and also important to keep in mind the context. So in the same study, if we look at individuals over age 65 compared to individuals, I think it was 25 to 45, that doubles your crash risk. So we're not going around to say like everybody over the age of 65 needs to give in their license because they're more likely to be responsible for their crash. So I think it would be unfair to say the same for individuals with schizophrenia. Similarly, I think the best laws around blood alcohol level would be a zero tolerance from an injury perspective. That would certainly be the best level. There's some evidence to show that individuals who have a blood alcohol content below 0.05, who would be subject to they wouldn't get a ticket, they wouldn't get a criminal conviction, it's totally fine. They just had a glass of wine at dinner. Those individuals are probably at double the risk of being involved in a fatal crash compared to people who have a blood alcohol level of 0. But we've said in our laws, like, that's okay, we'll accept the doubling of crash risk because it makes it easier for whatever our justification is. So I think it's really important to keep in mind those guardrails or those sort of sense of scale when thinking about crash risks and medical conditions, which people often don't have any control over.
Perfect, thank you.
We have a comment from Dr. Sean Pack. He says, to overcome administrative barriers, it is worth contacting the Office of the Provincial Health Officer. In each province, you may find that the legislation enables the Provincial Health Officer to access data to address a public health issue. So perhaps that may be one avenue to go to get access to data.
That's a good suggestion. Yeah.
Okay, we're almost at time. And so I'd like to take this opportunity to thank you very much, Dr. Staples, for this very, very interesting and insightful presentation. And, I guess you will be connecting with others who want to hear more about your schizophrenia research. But if there's any information you would like to, you need please connect with the unit, and we're happy to connect you with Dr. Staples as well. So thank you so much, everybody, and have a good rest of the day.
Thank you.